Good morning, cohort 14. It's April Fool's Day, Wednesday, April 1st. April Fools to you. Happy Hump Day, middle of the week. Today we're going to talk about Chapter 22, drugs that affect the circulation. So we're going to talk about antihypertensives, antiagonals, so those things for chest pain, and antithrombotics, okay? Those that we're going to need to thin our blood. All right, let's get going here if I can. My computer's saying no. All right. Again, so we've talked about blood pressure now 2 weeks in a row. So that should tell you how important blood pressure is. Okay. I gave you the blood pressure guidelines. So that's something you could follow, something you'll probably see on your next test. Okay. High blood pressure, anything that's considered high blood pressure is anything that's 140 over 90. Okay. And usually what we say is we call primary blood pressure or secondary blood pressure. Primary would be we don't know why they have it, they just have it. That's essential hypertension, and that's hypertension that most of the people have. If it's secondary, it would be known to a certain disease process that lends itself to high blood pressure, okay? So like if you've got pulmonary artery disease, you may have secondary hypertension due to that pulmonary artery disease, peripheral artery disease, those kinds of things. So most people think that blood pressure, having high blood pressure is pretty benign, doesn't really do anything that bad. Unfortunately, having high blood pressure will affect your heart, your brain, your kidneys, your eyes, and we call it cardiovascular disease because of the way it affects your heart. So how do we diagnose blood pressure? All right, I'm going to tell you all this. Just because you have one blood pressure taken that's high does not mean you have high blood pressure. You have to have your blood pressure taken 2 or more times on different days, okay? So you go to the doctor's office, they say your blood pressure is a little high. Okay, we're not going to tell you have high blood pressure. Either they're going to tell you to take it at home every day for about 5 days, and then you're going to report back to us. And if it's high every day, or at least 2 of those days, we're going to say you have high blood pressure. If it's not, then you don't. Something happened, white coat syndrome, had a bad day, running late to the appointment, ran up the stairs, and your blood pressure was just a little high. All right. What does this mean when you have a diagnosis of high blood pressure? Okay, so it leads us to have a couple of things that can happen. We can have left ventricular hypertrophy, which means my left ventricle gets too big. If it gets too big in an athlete, that's great. That means it's going to squeeze better. It's going to hold more blood. I'm going to squeeze more out. When I squeeze more out, I get more cardiac output. And those of us that aren't elite athletes, it's bad because that left ventricle gets big. It doesn't squeeze any better, and it actually cuts down on the amount of blood that's able to get into the left ventricle. Okay. It can cause angina or angina, however you want to say it, tomato. Okay. Chest pain. All right. It can be just benign chest pain, or it can be chest pain that's going to lead to a myocardial infection or heart attack. It can lead to heart failure, stroke, peripheral artery disease, retinopathy, renal failure. So it can lead all of this high blood pressure. If you don't take care of it, you're at an increased risk of all of these things, one or all of them. Okay. So what is this arterial blood pressure a product of? And we've already talked all about it, right? Systolic over diastolic. It's the amount of cardiac output that's able to get out and total peripheral resistance. So how much cardiac output, how much blood am I going to get out in respect to the total resistance that I'm trying to push against? Okay. Now, I know y'all remember this, preload and afterload. Okay. So preload is basically the major factor that we see in systolic. Okay. And afterload is the major factor we see in diastolic blood pressure. Okay, so basically preload is the stretch. How much blood can I get in there? And afterload is basically what's left when all the pumping is done. All right. So let's talk about hypertensive crises. All right. So let's say we have a patient whose blood pressure is greater than 180 over 120. Okay. So we can categorize that in different ways. We can say this is a hypertensive urgency situation, meaning this patient's feeling no signs or symptoms. Okay. And this does happen. Somebody who's got this crazy blood pressure, 180 over 120, they don't have any signs or any symptoms, no headaches, no shortness of breath, no palpitations, none of that. Okay. They have no signs, no symptoms of any organ complications. So my heart doesn't look bad, my kidneys don't look bad. They may have a headache, they may be short of breath, we may get some nosebleeds, severe anxiety. Okay. If this person comes in, we're going to control it and we're going to bring it down slowly over 24 to 48 hours. Meaning when they come into the ER, I'm not just going to throw them on crazy meds. We got no organ involvement at this time. So we're going to give them, what's the first thing we're going to give them? We're probably going to give them a little bit of fluid and see if we can't help out. Then we're going to start giving them some antihypertensives to help bring down that blood pressure slowly over a period of 24 to 48 hours. So they may just be up in observation. Over that time frame, we don't necessarily have to admit them. They'll be in observation. We'll get this done, and then we'll send them home. Okay, then we have an hypertensive emergency. Okay, meaning there is either some acute injury to an organ, chronic. We see it, and the kidneys are already bad, the heart's already bad, or it's getting progressively going from heart to kidneys to eyes, whatever it is. This patient will go into the ICU. We'll do some BP monitoring. They'll stay on a blood pressure cuff, and we're going to start to bring that blood pressure down immediately. So what are our first line agents that we're going to give? Okay, angiotensin converting enzyme inhibitors, or ACE inhibitors. Okay, ACE inhibitors, and they're all going to have PRIL at the end of their name. Okay, then we have angiotensin 2 receptor blockers, which are ARBs. We call them ARBs. Calcium channel blockers, beta blockers, and then remember we talked about those diuretics, those thiazide diuretics, hydrochlorothiazide, which is a first-line agent when people have high blood pressure. A second-line agent, so if this first-line agent isn't doing it, we can add in something else, or if these just aren't doing it, we're going to add something else. We can give them a vasodilator, an alpha blocker, an alpha-2 agonist, or an anti-adrenergic. Okay, and we're going to talk about what all those are. All right, so let's talk about these ACE inhibitors. Okay, so ACE inhibitors, and we're going to talk about this renin angiotensin aldosterone system. So we remember that aldosterone, right? If I make more of it, I'm going to pee more. If I hold back more, I'm not. Okay, so that's this whole system. So I'm going to block. So we have to have angiotensin 1 to convert to angiotensin 2, and that's what's going to create this aldosterone, or not create the aldosterone. Okay, so we're going to try to suppress that system. Okay, what can happen if I suppress this system? I'm going to reduce my peripheral artery resistance, okay, which then will decrease my total resistance. I'm going to increase cardiac output, and I'm going to increase renal blood flow, okay? But remember, we said about 20%, 22% of all cardiac output runs through our kidneys. Okay, so this is the renin angiotensin 1, angiotensin 2 aldosterone. Okay, so here's angiotensinogen, angiotensinogen. Okay, it's going to come down. It's going to make angiotensin 1, which is going to make angiotensin 2, which is going to have these receptors, which is going to cause vasoconstriction, which is then going to increase pressure, okay? We're going to either have aldosterone secretion and sympathetic activation, right? So the drugs are going to work on different areas in this system. And ACE inhibitors, okay, so ACE pathways right here are going to stop this from happening, this angiotensin 1 to angiotensin 2 pathway, okay? All right, so what are these ACE inhibitors indicated for? So we're going to give them for hypertension, heart failure, systolic dysfunction, to prevent an MI, if I've got left ventricular dysfunction, diabetic neuropathy, okay? They work well alone, but I can also put them with a thiazide, such as hydrochlorothiazide, and they work really well. They're going to decrease your systolic and diastolic about 15 to 25%, so about 20%. And what we see is a dry cough, which is why I'm no longer on lisinopril, which is an ACE inhibitor, because of the dry cough. You can, and it's not as rare as they're saying right here, rarely angioedema. So what can happen is you're taking this and all of a sudden your throat swells up because it's all this edema in the tissues. And if you have to get to the ER right away, you have to get intubated. If you don't, you're going to get a trach. And basically they have to take you off the meds and they have to just let this edema go down from the meds. And it typically happens, we see it more in women than we do in men. And it's not a first time side effect. It can be you were on this drug for years and years and years, and all of a sudden it happened, or it can be 2 weeks on the drug and it happened. It's just kind of hit or miss. Okay. It doesn't induce glucose intolerance. It doesn't give you increase in your lipids or an increase in pain. Okay. What we do say is that it does interact with NSAIDs, so we have to be very careful about that. Okay. So then the next class we have are the angiotensin 2 receptor blockers. Okay. So we have these receptors inside our smooth muscle, our heart, our brain, our kidney, liver, uterus, adrenal glands, all of that. And so these will be given again for hypertension and heart failure. They don't work as well as ACEs. They're a little bit weaker. But what we see with these is that orthostatic hypotension, where all of a sudden you stand up or get up from laying down and you feel dizzy because your blood pressure just kind of drops. It can lead to hyperkalemia, okay, so a high potassium, neutropenia, nephrotoxicity, and toxicity. So if I'm pregnant, guess what? This is not the drug you're getting. Okay. We have direct renin inhibitors. That's going to basically inhibit that renin so that pathway never starts. Again, they can be used alone or in combination with other ones. Aliskiren is the only one available. You don't see it given all that often because of the side effects. A lot of diarrhea, headache, dizziness, fatigue. It leads to nasopharyngitis, upper respiratory tract infections. So this is not one. Basically, we've used what we can use, and now we're going to try this one. Okay. Calcium channel blockers. Okay, so calcium channel, because calcium does what? It provides how much squeeze we're going to give, right? So in any muscle, we need calcium to come in along with sodium and potassium, but calcium is going to be what's going to decide how heavy is my squeeze, okay? So the two that we have here, verapamil and diltiazem, which is cardizem, okay? They're going to cause, okay, here are those words again that you got to know, negative chronotropic and inotropic effects. So if they're negative, that means my heart rate's going to do what? Go down. And inotropic, that's the squeeze. That means my squeeze will be a little less, okay? We'll have long-acting formulation, so you only have to take them once a day. We see lots of constipation with this. And then the other general side effects like GI disturbance or headaches and dizziness, okay? So some of the other ones we can see is amlodipine, Felodipine, idropine. Okay, so these are penes. Do we see that? These calcium channel blockers were penes. Okay. Most of them really don't do anything to the heart rate. All right. And basically, some of these are used more for heart failure than they are for hypertension, because in heart failure, we don't want the heart to have to work as hard. Okay. Come on. There we go. All right. So beta blockers. Beta blockers ends in LOL. Okay. So basically beta blockers, right? So that's going to be beta 1 and beta 2. We have them all over. We know that. So some heart rate and beta 2 are those in that smooth muscle inside our lungs. Okay. But it's also in smooth muscle. Those beta 1s are in smooth muscle around the rest of our body. So we can use these for hypertension, chest pain, any kind of cardiac arrhythmias. If I'm trying to keep a patient from getting an MI, they already had an MI, if they've just had an MI. We also use this for patients who have chronic migraines and who are going through alcohol withdrawal. Okay. So if I've got my patient who has COPD or asthma and we give a beta blocker, right? So now all of my beta receptors or most of my beta receptors will be taken by this beta blocker, and you give albuterol, guess what's not going to work as well? You're a beta agonist. You may have to give something different. So think about that. If you see that, you may give Atrovent, okay? Give Atrovent. It's an anticholinergic, right? Not Xopenex. That's still a beta agonist, okay? Okay. Then we have the diuretics. And we just did diuretics, so I know you know the 5 classes, right? CA inhibitors, osmotics, loops, thiazides, potassium sparing, okay? Which one do we typically use for hypertension? Thiazides. If those are not working, loop diuretics can be very well, but they're high ceiling. Remember, they're going to work instantly. It's going to make the patient pee a lot. So a lot of times we'll use those potassium sparing ones when we're going to combine it with another drug as well. Okay. So osmotics, CA inhibitors aren't used as often with hypertension. All right. So this potassium sparing, very weak. All right. So a lot of times what they'll do is if I'm using a thiazide, if I'm already using hydrochlorothiazide, they may, and my blood pressure is still a little high, and we don't want to add something like an ACE or a beta blocker or something like that, we could add in this potassium sparing diuretic because it creates like an additive effect with the thiazide. Midodor, droninium. Okay, again, I'm already taking one diuretic, so I'm going to be peeing more, even though this potassium sparing is supposed to help keep the potassium. Cramps, diarrhea, headache, dizziness can be a problem here because I'm going to be losing some potassium from that thiazide. Okay, so the thiazides are what we love. It's the first line. I'm going to increase sodium and chloride excretion. When I do that, that's salt, right? Sodium, chloride, salt. When I let let go of salt, water follows it. Okay, so if I've got hypertension, chronic edema, chronic heart failure, ascites, these thiazides are what they're going to do. All right, it's going to take about 2 to 4 weeks once I start taking that thiazide to get full effect. Okay, so what do we have to worry about? I'm going to be excreting the sodium and chloride, so I'm going to have low amounts of calcium, low amounts of potassium, because all that's going to follow with it. I'm going to be peeing a lot. My glucose can be a little high, so you have to worry about that. My lipids can get a little high, and we can see some sexual dysfunction. Okay. The loops, right? So the loops don't let me reabsorb sodium. So I'm going to, where sodium goes, again, water goes. So these are my chronic heart failure patients, ascites, renal failure, pulmonary edema, If I've got too much calcium, too much magnesium, if I've got this antidiuretic hormone syndrome that it's producing too much, we'll give a loop diuretic. Okay. It's my second line treatment, not my first line. All right. Second line. So now I'm in chronic heart failure. I need something a little bit higher dose, and I need something that's going to work much better. Okay. Because you're going to pee a lot when you're on Lasix. All right. And again, can cause hyperglycemia. So we have to watch sugars. We have to watch how much they're peeing. Okay, it can cause photosensitivity, ototoxicity. So we're going to watch for all of those types of things. And then aldosterone agonist, spironolactone. What was spironolactone? It's a potassium sparing diuretic, and Inspira. Okay, those are two aldosterone antagonists, which means they're going to compete against the aldosterone receptors. Okay, so spironolactone is a weak diuretic. We're going to put it with something else, like we just did with the thiazide. So if we'll see this a lot with cirrhosis, hyperaldosteronism, hypokalemia, heart failure, but we're going to use it in combination. Okay. So in guys, it's going to cause impotence. Okay. Deep voice, menstrual irregularities. It can cause women to grow hirativism. So not even in men, but in women, they're going to grow some hair in places they probably don't want it. Okay, so that's the spironolactone. And then the Inspira we'll see for hypertension and post-MI heart failure. And again, some minimal sexual side effects, but the higher risk is the hyperkalemia. So we're going to hold on to all the potassium so we could end up with a high potassium level. And we all know high potassium level is going to lead to heart palpitations and more likely to have arrhythmias. Okay. All right. So we have centrally acting adrenergic agents. So these are going to be our alpha 2 agonist, which are going to affect cardiac output and peripheral resistance. It's a negative inotrope and a negative chronotrope. So what does that mean? Yes. Decrease in heart rate, decrease in force of contraction. Okay. They work really well. Lots of side effects. So they're going to give us a lot of anticholinergic effects. And remember, anticholinergic effects is going to dry you out. Okay. And it's going to do those kinds of things to you. All right. The one we see the most is that clonidine, and it's actually a transdermal patch that you wear. So these are going to be patients who we've tried all these other things typically, and now we're going to these alpha 2 agonist drugs. Okay. We have alpha 1 adrenergic agonists, so they're going to block the alpha 1 receptors. So they're going to cause arterial and venous dilation. So I'm going to dilate all of the venous system and the arterial system. So I'm going to decrease preload, decrease afterload. So we have what we call this first dose phenomenon, where that first dose leads to tachycardia, palpitations, orthostatic hypotension, headaches, feel like I'm gonna faint. So basically they start you off in a really low dose before you go to bed so that this doesn't happen, and then they work their way up. Okay. So again, hypertension, prostatic hyperplasia, heart failure, Raynaud's. So if anybody has Raynaud's, and if you don't know what that is, basically your hands are always cold because and your hands are always red, and basically it's your vasculature in your hands and your feet that when you do any kind of go out in any cold weather or exercise, they just squeeze, so you don't get enough blood flow there, and everything gets really white and streaky, but also a little red. Okay. And it can lead to, if you're up north really, it can lead to some frostbite because you're not getting enough blood flow to your hands and your feet. Even here, it can cause a problem. Your hands will be very painful. Okay, hands and feet can be very painful. Okay, adrenergic agents. These are again second line drugs. Respirine, Emylin, Hydralol. Okay, so they're gonna again anti-adrenergic. And so we give adrenergics, right? So it's going to block that adrenergic agent, okay? So a lot of times what these will cause is it'll cause you to be sleepy, fatigued, again, some nasal congestion, diarrhea, right? So again, a lot of these are going to be in combination with other things. We haven't been able to get you controlled. And now we're going to add these things in because whatever we're giving you as a first line is not working. Okay. And then some vasodilators, hydralazine, Rogaine. So everybody knows that like Rogaine and Viagra. And just for everybody's knowledge, you typically will have a question on your board exam about Viagra. Okay. So just so everybody's aware, Rogaine was not meant to be a hair growth drug. It was touted to be a hypertensive agent because it's a vasodilator. And because it vasodilates, your hair will grow. Okay, that was one of the side effects. And because of this side effect, they knew they couldn't market it really as a hypertension or a blood pressure drug because how many people, how many women are going to take Rogaine and have hair grow all over them, right? Not very many. So they knew, oh, look, it grows hair. So voila, they made Rogaine, and now it's a supplement to grow your hair when you've got baldness, right? So, but it can be given as a vasodilator, just like Viagra. So Viagra will dilate everything, and I mean everything. So what we use it for now, specifically when we talk about Viagra, is for pulmonary artery dysfunction. So when you have pulmonary artery hypertension, okay, you'll see Viagra used sometimes. We use it a lot in the baby world for the neonates, and they don't call it Viagra. They call it by its generic name or its trade name, Sildenafil, but that's given because it dilates the pulmonary artery very well. Okay, so that drug was not meant to do that. That's what its original use was. But then when they started in trials and it gave men long-term erections, they're like, okay, we can't use this for men and women who are older who have certain heart diseases because it could kill them. It can bottom out your blood pressure, right? Okay. So this is going to decrease our total peripheral resistance, these vasodilators. Again, second line treatment, not a first line treatment. It can cause reflex tachycardia. It's going to increase that CO, okay? And we typically are going to see this given with a beta blocker or Lasix, that loop diuretic, okay? All right, so let's talk about chest pain. We just finished up with hypertension, but let's talk about chest pain. Why do we feel that pain in our chest? Why is it here? So we're going to differentiate. We're not talking about pleuritic pain here. Right now, we're just talking about myocardial pain. So chest pain coming from the heart. And you can differentiate those, right? So that chest pain coming from my heart is going to be that pressure, dull, feels like somebody's sitting on my chest, whereas pleuritic pain or lung pain is going to be that real sharp, feels like it's stabbing me. It gets worse when I inhale, better when I exhale, okay? So just remember that. So those are going to be descriptors so that are going to help you differentiate. Are they talking about heart pain or lung pain, okay? So if we're talking, just talk about heart pain right now. That's a symptom that I'm not getting enough blood flow to my actual heart muscle, okay? So I've got this chest pain and now my heart muscle says, hey, I'm not getting enough blood and you're making me work. I'm going to send you a message that says you need to slow down, and that's chest pain. All right, so the amount of O2 that my heart is requiring, it's not getting it. So my demand has increased, but I'm not getting it, okay? So it's that heavy pressure, it can be burning, shortness of breath. Now, the classic is the pain over the sternum, the left shoulder, the lower jaw, down into the left arm. Okay, that's classic white man how most men over the age of 50 will present. Most women will not present that way. Um, different ethnic groups will not present that way, so be very careful. In most women, it's stomach upset, back pain, shoulder pain. Okay, so what do we give when they come in for chest pain? All right, so I've told y'all this from day one. You go into the ER and say, I'm having chest pain. Okay. The first thing they're going to do is, especially if you say it's really bad, it's a 10 out of 10, they're going to put oxygen on you right away. Because what did we just say we had an imbalance of? We have an imbalance of what the heart is getting to what it's demanding. So if I give you oxygen, hopefully I'm going to help supplement what you're lacking. Okay. Then once I give you oxygen, that's going to be the first drug I give you, because oxygen is a drug. Please remember that. Then I'm going to give you what we call a nitrate, nitroglycerin. And yes, nitroglycerin goes boom as well. Okay. Little bitty pill, put it underneath your tongue. Okay. And it's going to dilate your vascular system in a big way. And so what we tell people when we give them nitro is you're going to have one of the worst headaches you've ever had, because it's going to dilate everything, including the vasculature of your brain. So now what is a headache? A headache is always too much blood flow to the brain. Not that it's your vasculature squeezing, it's the opposite. You're too much blood, too much edema, okay, in your brain's world. So we tell them you're going to have the worst headache you've ever had, and we can't really give you anything because we need to not mask the chest pain that you're feeling, okay? So these nitrates we're going to give for that chest pain, an acute MI, hypertension. So some people will have nitroglycerin at home, and they're told that the first time you feel chest pain, drop one under the tongue. If they do that, they've got to come into the ER. So you've got to call 911, or you've got to have someone bring you in. So how are we going to give this? They have it orally, IV, ointment, transdermal, translingual, and sublingual. And we typically in the ER, they're going to give you this little bitty pill, tell you to put it under your tongue and let it dissolve. They're going to put it in there every 5 minutes. Okay. And if you're doing it home, if you're doing it every 5 minutes times 3 and nothing's changing, you better get in right away. But typically we'll put it under their tongue and we'll see if anything changes. So we'll give it up to 3 times. And if nothing's changed, then we're going to have to change drugs. Okay. So yes, I'm going to get tachycardic. I'm going to get palpitations, hypotension, dizziness, flushiness. And I'm telling you, the worst headache you've ever felt in your life. Okay. I'm not going to ask you to know how nitrates work, but it's going to work on decreasing the calcium channel to make your smooth muscle relax so it won't spasm. Okay. So another one we can give is called Ranexa, but this is basically going to be for chronic angina. Basically, you're having heart pain, chest pain a lot, and it's not necessarily enough to bring you in, or you've got heart failure, so you're always having this kind of angina. So we give you Ranexa. Okay. So basically, I'm going to go from a fat oxidation to a glucose oxidation, so I use less oxygen. And if I use less oxygen, my heart's happy about that. Okay. Again, dizziness, palpitations, headache, nausea, pain, and we get rid of it through our liver. So if I've got liver issues, this is not a drug I'll give for that chronic chest pain. Okay, so those are really all I want to really talk about chest pain. That's it. See how easy that was? Now we're going to talk about antithrombotic agents. So these are going to be the agents that are either going to prevent a clot or break up a clot. So drugs are going to be classified in 2 different ways. They're either going to be, I don't have a clot and I'm giving you this drug to keep you from getting a clot, or you've got a clot and now I need to give you a drug to break up the clot. So please remember that. They're going to be separated based on that, okay? So I know all of you remember how a clot forms, right? So you have to have some kind of injury to your endothelium somewhere. There has to be some kind of injury sensed so that we set off the cascade of mediators that are going to bring platelets to the area. And if we bring platelets to that site of injury, Okay, then the platelets come and they're going to send out a signal that says, hey, I need you guys to come here and help me. And other agents are going to come and we're going to create, remember the fibrin is going to come and we're going to get our fibrin clot. Okay. And if that happens, we have to remove that clot, because if not, everything gets backed up behind it and we can't get back to homeostasis. So remember that. Okay. But if I don't have a clot, but I'm at risk for a clot, we will give you agents that are going to help prevent that. Now, does anybody know the most common arrhythmia where we're going to give an anticoagulant, such as heparin or Coumadin? Okay, or one of the others that's out there. But AFib, right? So atrial fibrillation. If my atria are fibrillating and not really pushing, really squeezing like they're supposed to, I'm at an increased risk of getting a clot in those atria because it's not truly letting all the blood squeeze out. And so I'm having a backup of blood in my atria, which can lead to an atrial clot, which then that atrial clot can leave my atria, go into my ventricles, go into my lungs, yada, yada, yada. Okay. So if someone's got AFib, guess what they're getting? They're going to get an anticoagulant. Okay. So like I said, we've got these three categories: an anticoagulant, an antiplatelet, and a thrombolytic. Okay. So let's talk about, and we already kind of talked about what sets off this platelet aggregation, right? That I have to have some kind of injury. So even sitting for long periods of time, and your blood, especially if you have some other factors such as high blood pressure or peripheral artery disease that doesn't allow blood to be distributed easily up to get back to your heart, then blood's going to pool, and we sense that as an injury and it can create a clot. Okay. So basically these clots we have to trigger that platelet. So we have to sense some kind of injury. Okay. So let's talk about anticoagulants. So this is, I don't have a clot, or I had a clot and we've gotten rid of the clot, and now I need to make sure you don't get the clot again. We're going to give an anticoagulant. So we're going to make that blood thinner. Okay, so what blood tests do we do for this? And I know you guys know it, right? INR, PT, PTT. Okay, those are the tests that we're going to do when we give these anticoagulant agents, because I don't want to make your blood too thin, but I have to make sure I've made it thin enough so we're not likely to clot. Okay, so when am I going to use heparin? So typically heparin is, you've come into the hospital, we've sensed that you've got some issues, or you had a clot, we've gotten rid of the clot, so now we're going to keep you on heparin. Or, so if you think about, if you watch the nurses in the ICU, they're going to give heparin shots to the patients who are just laying there, right? My patient on the ventilator who's not moving around, we'll give them heparin to make sure that they don't clot while they're lying there. Okay. So when do we give heparin? If I've got a venous clot, a pulmonary embolism, AFib, DIC, peripheral artery embolism. Okay. And where do we get heparin? Yes, we get it from pig intestine. The mucosa of the pig intestine is where we get it. Okay. So the goal of heparin, okay, and we got to balance that clotting with the risk of hemorrhage. So that's why we do the INR, the PT, and the PTT, to make sure we don't make their blood too thin. So the side effects are an increase in bleeding. So when you do your gas, if that patient's on a blood thinner, you have to hold pressure longer, okay, because it's going to take them longer to clot. Thrombocytopenia, hyperkalemia, an increase in liver enzymes, so we have to watch that. Okay, but if we were to give someone too much heparin, we do have an antidote, kind of like Narcan, okay, for an opioid. But for heparin, we call it protamine sulfate, and basically it will deactivate heparin, and then the blood will come back to its normal viscosity. Okay. We have direct thrombin inhibitors, which we called Desrudian. So basically you'll see this used for DVTs, okay? And another one called Angiomax. So if I've got unstable angina, meaning we've seen some EKG abnormalities with this angina, we can give Angiomax, okay? We can use this other one, Rafludan, for if I had some problems when we gave heparin, okay? Again, what is the major adverse reaction? Hemorrhage, because I've made your blood too thin, okay? Then we have warfarin. This is what you're going to be on when you go home, okay? It's oral, it's a pill. So again, DVT, pulmonary embolism, AFib, valve replacement, coronary occlusion. So when patients get valves replaced, they're now going to be on Coumadin therapy for the rest of their life because we don't want any clots to form around that valve we've replaced, okay? So you have to dose it daily. So every day you're taking it, okay? And it takes about 3 to 5 days to see exactly, once we start this, where our numbers are going to lie. So we do that INR, PT, PTT, right? Okay. And we, again, hemorrhage. So we tell people really watch, you're going to bruise, you're going to bruise easier. The guy, when you shave, be very careful, because if you cut yourself, it's going to take a while to stop bleeding. So here's the issue with Coumadin is diet, disease states, and drugs. So when we talk about diet, vitamin K is the big one. If you eat too much vitamin K in combination with taking Coumadin, it's going to make your blood even thinner. So we have to tell patients to really watch that green leafy vegetable, anything that's got high amounts of vitamin K in it, okay? Aspirin. Aspirin is the biggest one. So if someone is at a risk of heart disease, what do they tell them to take? A baby aspirin, okay? So basically, aspirin will help thin your blood by not letting platelets aggregate, okay, is what they do. They inhibit that platelet aggregation, okay? So those patients who have had a stroke or have a history of stroke, have some coronary artery disease, or have a history of coronary artery disease in their family, they'll tell them to take an aspirin a day just to help thin out the blood, so we can hopefully keep, and it's going to be an antiplatelet, I'm sorry, we got into that, just not going to let those platelets aggregate, okay? All right, so what do we have to worry about with aspirin? That it gives you an ulcer, okay? It can cause some hypertension, some ringing in your ears, okay? So what we have to watch out for is it causing this peptic, this stomach issue? And so they give you, you take basically a baby aspirin or a coated aspirin, so it's not so hard on your stomach, okay? And ibuprofen and the rest of that is not going to thin your blood. So you cannot take acetaminophen, Tylenol, and those kinds of drugs, because they will not thin your blood, okay? Dipyridamole is a second antiplatelet, okay? It's a vasodilator and platelet adhesion inhibitor. So the platelet can come, but kind of coats your vessel so that platelets won't stick there. So kind of like putting Pam in your skillet, so it's a non-stick, so the platelets won't stick there, okay? So typically where we see this used is in a combination with Coumadin, and usually we do this after they've had valve replacement, so it's in the hospital, and it's not typically something that they'll go home with, but after surgery, after valve replacement specifically, we see this given, okay? Okay. Plavix is another one. And basically it's a very pro drug, which means it has lots of side effects. Okay. But it works, and you'll see a lot of patients that, they're going to come in for a procedure, and they'll say, have you stopped your Plavix? Okay. So basically, again, it's going to stop platelets from being able to congregate together. Okay. It does work. It works a little bit better than aspirin, but not a lot. So, price wise, if we're worried about price, aspirin is totally acceptable to use if you don't want to use Plavix. The only time we really like Plavix is those patients that have stroke. And Plavix works really, really well, okay? The issue here is it's got to be metabolized by the liver. So if I have any type of liver issue, Plavix is not going to work, or I can have an increase in it in my system, okay? Usually once we start taking Plavix, it's going to start to take anywhere from 3 to 7 days, so around 5 days for us to have Plavix at the level that it's going to be working, okay? Ticlodipine, again, is another one, and it's for stroke. So we see a lot of these antiplatelets really used in the stroke area, okay? Again, more effective than aspirin. Takes about 2 weeks, 3 weeks for it to get to work, okay? And typically, if we've tried aspirin or Plavix and they're not working, then we'll use this one. But we see that it causes some issues with the red blood cells. So we try to stay away from this drug unless aspirin and Plavix have not worked, okay? Presergel is another one. And again, we see this and we give this to patients who are going to be going in for cardiac caths, okay? And we'll give this to them prior to that so that we don't have any clotting issues when we're doing the cardiac cath. So if we're scheduled for a cardiac cath, you'll see this drug given to the patient, okay? We can also give it outside that, and we can give it in combination with an aspirin for patients who have had MIs and we're worried about clots, okay? Again, bleeding is going to be our issue with all of these, okay? Again, clystozole and this other one are both going to cause vasodilation. And when we cause vasodilation, it doesn't allow platelets to aggregate. We see this for peripheral artery disease pain. And again, really for that and that peripheral artery disease realm, okay? I'm not going to ask you to know these type 2 and 3 inhibitors, so don't worry about that. Okay, so let's talk about thrombolytic agents. So I've already got a clot. I've got a PE. I've had a stroke. I'm having an acute ST segment elevation, MI. So what does that mean? It means when you look at my EKG, the ST segment is high. It's above the baseline, okay? So what kind of agents do we have? Streptokinase, Alteplase, Reteplase. Okay, do you see the ACEs at the end, meaning they're all enzymes, okay? And all these enzymes go in there and eat up the clot, all right? So this is the problem here. They all have really tight protocols, and you have to begin it within 12 hours of the symptoms. So if I'm having shortness of breath, or I'm having this heart attack, but the symptoms started yesterday, 24 hours ago, I'm not going to be eligible to get these because they should be started within 12 hours of the symptoms, or they typically don't work well and can cause some fatal issues, okay? We like to give these instead of actually going in and doing the cath and, going in, okay? But if I have to, we will take them right in and do that Roto-Rooter where we go in and do the cardiac cath, okay? What are some issues with these excuse me, with these thrombolytic agents? I can get some internal bleeding, an aortic dissection, head injury, or stroke. Okay, so if I've had a head injury or stroke in the last 3 months, I don't want more bleeding, okay? Hypertension, if I'm already using an anticoagulant, I cannot take it because now I'm really going to bleed, okay? Bleeding hemorrhage is the number one thing. I don't want to make them bleed out, okay? So that's a huge issue with these thrombolytics, okay? That's everything, guys. We're going to talk about our final here in a couple of days because we will have a new way to give our final, and we will talk about that. Okay. All right. Y'all have a great Wednesday. And I miss seeing y'all's smiling faces.